My name's Kevin Gibbons. I'm the Senior Associate Dean for Clinical Affairs at the Jacobs School of Medicine and Biomedical Sciences here in Buffalo, New York, and the Executive Director of UBMD Physicians Group. I'd like to take this opportunity to talk to you about COVID-19 disease and what's going on in our community right now and the steps we have to take to get this under control. The healthcare leaders in Western New York have been working hard, especially over the last week or two, as we look at rapid increase in the amount of this disease in our community. I've spoken to numerous people in hallway conversations explaining what's going on, and it's been suggested that we record this and put this out for our patients and the members of our community. We've done town halls for our physicians over the course of this pandemic. We've had town halls for our patients as well. And it's time to update people as to where we stand, because it's at the point where we all have to do something to get control of this situation. I'm going to screen share now and go over some of the things we've learned and what we need to do to get control. So I'd like to review what we've learned. I want people to understand why we are where we are right now and what we have to do to avoid, quote, the dark winter, as experts such as Dr. Fauci have suggested is certainly coming upon us. The good news is there's been a lot of progress made. We know a lot more about this virus now than we did in February and March. The good news is this virus has been very stable genetically, meaning the antigen is stable, meaning immunity is likely, and vaccines are likely to work. There's been a lot of news about that in the last few weeks. We know who gets it and we know who dies from it. We know that fatalities occur mostly among the elderly, those with comorbidities such as obesity, hypertension, diabetes, but we also know that young people can get this disease and they can die from it. We also know there's something called the long haulers. Those are individuals who are still suffering from effects of this virus 4 to 6 months after their illness. The good news is we have better treatments available. We use remdesivir for patients with mild disease, which prevents more serious disease. For patients who present with serious disease, dexamethasone drops the mortality rate by 1/3. Antibody therapy appears to be increasingly successful, and recombinant antibodies are coming to market over the last couple of weeks. We have better knowledge about how respiratory treatment works and doesn't work for this disease. And we understand the needs for anticoagulation in patients so they don't get blood clots, which could be a serious side effect of this disease. The good news is ICU mortality rates have gone down from 80% in March to now between 8 and 12% at most major centers as of September. We know how this disease spreads. It spreads via close contact through the air we breathe. We learned this early on when a choir practice in Washington state resulted in over an 85% incidence of infection in a group of people who are confined in a tight space singing for an hour and a half. Singing involves breathing deeply and breathing in and out deeply, and that's the way this disease is communicated. The picture on the right is that of a college bar. Those of you who've been there recently know they're loud, they're singing, dancing, hugging, and a lot of shouting in people's faces because it's loud. It's a terrible environment for the spread of a virus. Well, we know how this spreads. We understand how R factors exist. That's how many people are infected from a single person with this. Measles, an R factor can be 18. This virus, the R factor is between 2 and 4. We need to get that number down to less than 1 to stop this epidemic. And to do that, we need to understand the role of masking and the role and importance of isolation. This is a graph provided by the Western New York COVID-19 Analytics Group, and it shows that over the course of the summer, the testing rate in our community, the testing positivity rate in our community is basically between 1 and 2%. In the last few weeks, it's accelerated greatly. Those blue arrows on the right-hand side indicate that Wednesday and Thursday of this week, the testing rate went from below 5% on Tuesday to 6.4% on Wednesday and 8.3% on Thursday. So clearly accelerating. We also know that the positivity rate probably reflects about half of the disease that's actually present in the community, especially when it's accelerating. So if we have a rate of 8%, that means in reality, probably 16% of the people in our community are currently infected with this virus. I'm going to give you an example of what we've done right and what we have to do differently going forward. My pod, the people that I'm closest with, are my family, my wife and our daughter who lives with us right now. That's our pod of 3. We have meals together and we don't mask within our home. We have to realize, though, that over the course of months, we have groups that we work with outside of our immediate pod or family. These are people where there's 1 degree of separation. Could be coworkers of my daughter, friends of my wife. It could be a group that I work with regularly on a day-to-day basis and don't 100% of the time wear a mask, although we should. So in this situation, my original pod of 3 now includes in the 1st degree 14. But when you really look at it, it actually does get larger. My son and daughter-in-law come to dinner once or twice a week. All right. So now we're up to a greater number. We have 16 people. And that works for a while. We have to realize, though, that all these people that are in this 1st degree, they live in their own world and they have their pods, and we don't know what goes on there. It could just be a family with 2 other members, but it could be a basketball team with 8. And one basketball team plays with another, and pretty soon you add another 20 people or so into this group that you're sharing germs with, essentially. Hockey team, 20 plus people in very close contact, breathing hard. That degree of isolation was less than perfect, but we got away with it when the disease incidence was 1 or 2%. If you're dealing with a group of 16 and the disease in your community is 1%, there's a good chance that no one of those 16 has the disease and you're going to be okay. But it's also why the disease sort of rumbled along in the community at 1 to 2%. We never got rid of it because we never were really strictly, truly in isolation. But now when 10%, 1 out of every 10 people have the virus, regularly sharing germs with a group of 16 means some people in that group are going to get the virus and are going to get sick, and the spread is just going to accelerate from there. We know how to stop this. Our healthcare workers who work with COVID-infected patients on a daily basis in COVID units wear masks and have a very low incidence of infection. In fact, their incidence of infection is very similar to the community rate, meaning if they got an infection, they probably got it from the community, not from their work environment, where masking is the rule 100% of the time. The COVID working group in Western New York put out a bulletin yesterday strongly encouraging all healthcare workers and all healthcare providers to wear a mask, to insist that their staff and their patients wear a mask, and include the instructions on how to do that. Brief comment on masking. Proper masking. The picture in the lower left-hand corner is that of Harvey Cushing, the founder of my specialty, neurosurgery. Almost every picture of Dr. Cushing shows him wearing a mask with his long patrician nose sticking out over the top of the mask. That's not acceptable. And the picture of the mask in the middle, that N95 has a breathing valve on it. That's meant for people, for example, who are cutting granite or quartz countertops, who are worried about breathing in silica dust or bone dust, which can be dangerous. It's meant for them to breathe out easily. Well, in an epidemic, if the person who has the infection is wearing a mask with a valve, they're effectively spreading the virus. That valve protects the wearer of the mask, but it does not protect all the people around the person who's wearing that mask. So the bottom line is good cloth masks or good paper surgical masks, but no valve and no nose hanging out over the top of the mask. And we put the X over both Harvey and the N95 with the valve. So to get through this, for example, in my family, we have to wear a mask whenever we with anyone outside of our immediate smallest group. And I think that's the approach everyone has to take. That means no fans at the Bills Stadium, even though we would love to have it full of happy and screaming fans. We can't do that. We can't do that at this time. And in terms of the upcoming Thanksgiving holiday, the cartoon in the lower left-hand corner sort of summarizes, I'm afraid, what it's going to be like. There's going to be people missing. There's going to be empty chairs. I'd like to suggest to you that that's what we need to do so that those chairs are empty on a temporary basis, and that we're not facing a situation like in the lower right-hand side where there's an empty chair with a picture on it of someone who passed away from COVID-19. So that's what we have to do. In short, Western New York, we have to mask up, all right? And we can do it. I'm a surgeon. I wear a mask often 12 hours a day on an operating day. You can do it. You can get used to it. Basically, I'm in my office now with the door closed, but as soon as I get ready to go out, I have to put on a mask. I have to do it to protect myself and to protect the people around me. And it will make a difference for this community and the people of Western New York if we do it. So in short, Western New York, mask up. It's the only way forward. It's the only way out of this. Thank you.